Good morning, everyone. Welcome to the ESVNU pre-symposium in Barcelona. My name is Natalie Finch. I'm president of the ESVNU. We've got an exciting programme of lectures for you today. We will also be hopefully live streaming this event. We've got about 300 attendees across the world, so welcome to all our virtual attendees as well. We also have our lecture stream in the main ECVM programme, so I'd encourage you to attend that. We've got some excellent abstracts. And we have our AGM, so all ESVNU members, please attend the AGM. That's at 1:20 till 2:20 tomorrow in room 114. So I'd like to thank all our speakers today, and I'd also like to thank our sponsors, IDEX and Purina. So I'm going to hand over to Sylvia Conway from IDEX.
Thank you, Natalie, for that lovely welcome. So good morning, everybody, and welcome to Barcelona, and welcome to this ESVNU ECVIM pre-symposium. My name's Sylvia, as Natalie has already said, and I work for the Global Medical Education team at IDEX. We have a really packed agenda ahead, so I'm not going to waste too much of your time this morning. I just wanted to say that IDEX are really, really happy to be here to be sponsoring this event, or co-sponsoring this event today. And that I'm sure you're aware that many of IDEX's most important innovations over the last decade have been within the renal health area. So IDEX SDMA, IDEX FGF23, and soon IDEX Cystatin B will become commercially available. What I wanted to say is that we have a lot of IDEX people in the audience here today, so give us a wave, all the IDEX people. So they're all dotted about. So don't be a stranger. If you do have any questions about any of the IDEX renal portfolio, please feel free to raise these in any of the relevant sessions today, or to just connect with one of our team members over lunch or a little bit more casually at the booth if you did want to know anything more about our tests. I also wanted to just have a final plug for a new educational offering from IDEX called Springboard. So Springboard is a training program, online training program for residents. It's free of charge. So if you are a resident or you're supervising residents and you would like to sign up for our Springboard program, Becca Mack here in the audience is the lady you need to speak to. So please feel free to connect with her. I hope you all have a great day today and a great Congress in general. And I'll pass over to Maria from Purina.
Thank you, Sylvia. Can you hear me? Yes. Hello. So hello, everyone. Good morning. I'm Maria Castan from Purina ProPlan. I'm very pleased to welcome you as well in this Congress, in this pre-symposium from ECVIM. And I hope we're going to have a wonderful day. Apologies for the little bit delay, but technical issues are always in our way. So as I said, my name is Maria. I work in the veterinary team, and we are very pleased to show you here all the latest and better, the new things coming up for nephrology and urology. And we will welcome you at the ECVIM in the booth 16. So if you have any question, anything you would like to know, or get any samples for hydration, we have hydrocare products in there. You will also get some goodies, so don't worry, you will not be empty-handed. So please stay tuned at the break. You will get at the door, you will get some goodies from us. Without further delay, I would just like to say welcome and hope you enjoy the day. Thank you.
Just a few housekeeping things before we begin. If you can just make sure that your phones are switched on to silent. If you need the bathrooms, they're located if you turn left and go down the corridor. We're going to be taking a break between 10:30 and 11. All of our lunch and refreshments will be served down in the terrace area on the ground floor. So just head down there, make sure you have your badges on you to be able to access that area. For all of our virtual attendees, if you can submit questions via the chat function, and we'll pass those on to our speaker. And also just to remind everyone that we are recording these lectures and they will be made available after the symposium. So I'd like to welcome our first speaker, Lise Nielsen. Her first talk will be a review of coagulation. So Lise graduated from the University of Copenhagen. She did her internship and residency at Glasgow, and then she returned back to Denmark to do her PhD in hemostatic biomarkers in cancer in dogs. She's very interested in hemostatic disease in both the human research industry and also in academia. And she has a wide interest in hemostasis in a multitude of species. And she's currently the head of veterinary clinical pathology at the University of Copenhagen. Thank you, Lise.
Thank you so much. Just making sure that you can all hear me down there. Yes, good. So this is going to be a bit of a sprint because we have half an hour to cover hemostasis, which is, I could spend days looking at this, but we'll try to get some updates of what's more new probably, and then we'll also review what we know already. In a while. Oh, try again. Oh. No. Here we are. So I have a few disclosures. I'll not spend too much time looking at these. And the outline here this morning in the first talk is just looking at the generalized stuff about physiology of hemostasis. Then we'll not go through all the different hemostasis dysfunction diseases. We don't have time for that. We'll just pinpoint a couple of things that might be interesting and really leading into the second talk where we talk about the kidney and hemostasis. And then we're going to talk about the diagnostics, and particularly in the lab, what kind of diagnostic tests do we have available? And I have a great disclaimer here. I'm not going to talk about sort of advanced diagnostic imaging, which I actually think is a great part of also thrombosis diagnostics. So we will get someone else to talk about that at some point, I guess. So just getting back to basics about physiology, it's all initially about the platelet plug whenever we have some kind of rupture of our vessel. The ruptured endothelium will leave this open, this subendothelial collagen, which is quite sticky for platelets. And besides them sticking directly to the collagen, they will also stick directly through von Willebrand. And this will help activate the platelet, and along with secretion of different types of granules within the platelet will be more activated, will change forms, and also attract other platelets that will do the same. So we'll get this initial platelet plug where we have von Willebrand, fibrinogen, interlocking these activated platelets, and that will be the initial seal. There's not really much new in this, but we still think this part is actually quite vital in understanding some of the conditions where we see these sort of pinpoint bleeds. This might be sufficient to stop any kind of small bleeds, but we still often will need some more sort of robust clots, hence some kind of fibrin mesh to cover it up. So in the 1960s, this cascade model was coined to try to assess how hemostasis actually occurs, and it was very much focused on the coagulation factors. With the intrinsic leg, with the extrinsic leg going into a common pathway. And I just want to highlight there's a couple of things that we probably learned from then, is that even though we knew we had all these cascades of coagulation factors, we would produce first a 10-ACE complex, where phospholipid membrane was probably a much larger part of this, much more important than we initially thought. This would lead potentially to a common pathway activating factor 10 on this prothrombinase complex, and again, phospholipid membrane, probably more important than we actually thought. We might also see activation of the extrinsic pathway, so activation of tissue factor in the subendothelial space, and this would activate the very sort of unstable factor 7 leading into this crosslink that would also activate factor 10, leading into prothrombin to thrombin, thrombin into fibrin, which is then cross-linked by activated factor 13. So for many years, we thought that this model was probably how things were working. But over time, this kind of phospholipid part seemed to be much more important than initially thought, and therefore, maybe the cell-based part of it should require more focus. And also in human research, it was identified that human patients with hemophilia A or hemophilia B, so having deficiency in factor 8 or factor 9, could actually be treated quite well with coagulation factor 7. So potentially this part of the leg was much more important than the other leg. And this led to this new model production, which was the cell-based model in around 2000. And even though that's approximately 20 years ago, we still see new publications coming out that still refer solely to the coagulation cascade and doesn't really think about this cell-based approach. So again, here we have the rupture of the endothelium resulting in exposure of collagen or laminins or tissue factor. We have vasoconstriction, and we have these activated platelets and the initial platelet plug. But we now talk about the cell-based model as having an initiation phase, an amplification phase, and a propagation phase. One of my PhD students actually made this model trying to just show exactly what's happening. And basically, whenever we have the rupture of the endothelium, we expose a small amount of tissue factor. And this small amount of tissue factor, so the old extrinsic leg of the cascade model, will accelerate these coagulation factors into producing a small amount of fibrin that will then maybe be sufficient to stop the clot. However, if we have bigger sort of wounds, then we will expose a much greater proportion of tissue factor, and this will really amplify the process, but this time on top of the activated platelets. So that's where the cells is really vital for this to occur, and this will lead to a much greater proportion of thrombin and cross-linked fibrin. So this is really how we think this works today in the body, and it actually kind of fits with some of the tests that we have available today as well. So now we've formed the clot. We also have to lyse the clot. And this lysis happens in an almost sort of continuous movement, you might say. So even when you have the clot forming, you have the clot dissolution at the same time. So it's activated by TPA and urocinases, particularly from endothelial cells, but also from the circulating cells, or activated contact factors that will cleave plasminogen to plasmin. And plasmin is very efficient in cutting up fibrin into fibrin degradation products. So all that has really not changed very much in our knowledge for the last many, many years. But really about plasmin is that it also cleaves fibrinogen. So we get these sort of products from destruction of fibrinogen. And then we get these E fragments and D fragments, which are almost like monomers and parts of the fibrin degradation products concentration. But if we have cross-linked performed due to activated coagulation factor 13, we may also have D-dimers formed, and we'll get back to them because they're interesting in our lab testing. So with the clot formed and the clot lysed, we really only have left to talk about are the regulatory mechanisms. And there are sometimes, probably not in this audience, but sometimes quite often, I would say, forgotten about. So in our regulatory mechanisms, we have proteins that regulate both the clot formation and the clot lysis. Probably 70% of them are antithrombin, so it really plays a center role in anticoagulation. And it affects, obviously, thrombin, making these thrombin-antithrombin complexes, but it also affects several coagulation factors, deactivating them. Besides that one, we also have activated protein C and its cofactor, protein S, and tissue factor pathway inhibitor affecting directly on tissue factor and other coagulation factors. The endothelial also have some kind of inhibitory effect because they secrete prostacyclins and nitrous oxides that will deactivate our activated platelets. We certainly also have regulatory mechanisms in fibrinolysis, plasminogen activator inhibitor, PI1 and 2, produced by endothelial cells that will affect directly TPA. And in the circulation, we have things like alpha-2 antiplasmin, alpha-2 macroglobulins that will kind of engulf plasmin and inactivating it. Also, thrombin activable fibrinolysis inhibitor. I love the fact that they do abbreviations because these names are so long. So basically, we have a very sort of important regulatory mechanism in place as well. So this is a very tightly regulated process in normal hemostasis and normal physiology. And it's really all about balance, having this normal coagulability. So obviously, that's where we come into play, is that whenever we have this imbalance, right? So whenever we see bleeding, this can be due to hypocoagulability or hyperfibrinolysis, or perhaps some kind of dysfunctional regulation. Or thrombosis, where we see hypercoagulability or a resistant fibrinolytic potential, or perhaps a dysfunctional regulation. So there are several different parts we really, really need to look at to try to fully understand what's wrong with the patient. And we unfortunately seldom have all these options to look at all these different things. So I'll just take a couple of pinpoints looking at both bleeding and thrombosis, because I know that you guys probably see this, maybe not every day, but frequently in clinics as well. So whenever we kind of characterize our patients, because we have this initial platelet pluck and we have the fibrin mesh on top of it making our clot, we still try to sort of artificially divide this into different parts. The primary hemostatic problem, the secondary hemostatic problem, and the tertiary hemostatic problem, or the fibrinolysis. And I guess it still makes sense because we focus on specific parts of the hemostasis, but frequently we will have to examine different parts, or several parts of them as well. So in the primary hemostasis, we're looking specifically at platelet concentration or platelet count. We're looking at platelet function as well if we can, and von Willebrand factor, and we also want to or wish for looking at local vessel pathology. That's continuously an issue for us. In the secondary hemostasis problem, it's really mostly related to the number of coagulation factors. We don't tend to see in people, they may see these acquired factor deficiencies related to disease, and we do not tend to see that to the same extent. Wherever they have some kind of inhibitory effect on factors, we don't tend to see that to the same extent in our animals. Within fibrinolysis, there's a little bit more new information within the last couple of years with regards to hyperfibrinolysis. And that's definitely have to do with the fact that we are more sort of focusing now on what kind of tests we can use to measure hyperfibrinolysis. So we divide hyperfibrinolysis in primary and secondary hyperfibrinolysis. In primary hyperfibrinolysis, it's acquired in animals. In people, they have an inherited form as well. And we have seen hyperfibrinolysis associated both with cancer, liver disease, and, for example, Angiostrongylus vasorum infections. And we think it's related to an increased expression of TPA, but we actually don't know for certain. In secondary hyperfibrinolysis, we see an accelerated production of thrombin, and due to that, and also a physiological process where the body tries to get rid of the clots, and therefore also an accelerated fibrinolysis, but it can over-accelerate. And therefore, we may see that in quite a range of conditions, but often when they lead to DIC. I think what's important to say here as well is that patients that present with hyperfibrinolysis present with the same clinical signs as patients that present with a secondary hemostasis problem. So where we in secondary hemostasis problem might see sort of cavity bleeding like hemothorax or hemabdomen, that's the same kind of findings that we might see in patients with hyperfibrinolysis, and particularly the primary hyperfibrinolysis cases is where that's been documented. With regards to thrombosis, I know this is a very old model that I bring forward. It's kind of changed color a bit. It's not just venous thrombosis, but Virchow's triad to some extent can still explain a lot when it comes to the development of thrombosis. And if we try to look at both arterial and venous thrombosis all comprised in one, we can talk about alterations of blood flow, hypercoagulability, injury of the endothelium, or dysfunction of the endothelium. So within alterations of blood flow, this could just be turbulent blood flow, it could be venous stasis, it can be mechanical reasons outside as well. In hypercoagulability, we may have an up concentration in coagulation factors. This is something where we really have to think about the kidney, for example, or reduced anticoagulant, or we can have activation or hyperactivation of platelets. Within the endothelium, we may see reduced endothelial anticoagulant properties, so changes in their surface and their receptors. Or we may see, in fact, disruption of the endothelial sort of membrane, for example, in atherosclerosis. So it's a relatively rare condition in dogs and cats, but it does occur. So thrombosis is by far not as common as bleeding in our patients, but it's still something we have to be very much aware of, obviously, whenever it happens. And several conditions in our dogs and cats may appear hypercoagulable, but without actually developing thrombosis, and that's what makes it really tricky. However, thrombosis have been detected in a range of conditions but only prophylactic treatment are recommended in a small number of diseases. And here we'd just really like to highlight the work that's been done in the Emergency and Critical Care Society where in 2018 a sort of bunch of publications were made looking at what kind of populations at risk should we be aware of, how should we treat the patients, and so forth, with updates in 2022 as well. So I've tried to group them in different categories as best as I could. So, with these different consensus sort of documents, they were trying to look at the evidence, trying to look at what do we have out there of publications, what do we know, and what has high impact evidence as well, how strong was the evidence. And with that, you can sort of divide them into three groups. Into the groups of patients that are at high risk of thrombosis, where you want to treat them with antithrombotics. These would be the IMHA in dogs, PLN in dogs, PLE in dogs, defibrillaria, and transvenous pacemaker in dogs. In cats, the cardiomyopathies, basically different types, and arrhythmias and defibrillaria imitis. But then there would also be this large group of diseases in dogs and cats where there have been documentations of thrombosis, but very, very rarely, or whatever evidence we have, unfortunately, is rather poor. So these patients, they classified them, or these diseases, they classified them as being diseases where more than one risk factor should be present in order to treat them on a continuous basis, with a risk factor being, for example, more than one disease, or being, for some reason, a patient that was on corticosteroids and developed another condition, for example. And then you had a bunch of diseases where one could expect that some of these patients would develop thrombosis, but the evidence were really, really poor. So we all know that research in cats is usually quite limited, but really here we would, with the question marks, really say, but there's not really any evidence maybe that that these populations are at risk. So I'm not saying that this is the way things should be in the end for years to come. Basically, this is where we are now, and I would expect that there would be updates coming on a continuous basis, the more and more information that we get in this area. If we look at the lab diagnostic toolbox, what do we have to work with? Well, one of our biggest problems is really that we have lots of tests looking at bleeding, but we have very little when it comes to looking at thrombosis. So again, we divide them into primary hemostasis and secondary or tertiary hemostasis, and I've here clumped them together due to the fact that they present with potentially similar clinical signs. And we also have these global tests that I'll come back to. So in primary hemostasis, in particular for looking at bleeding, obviously we do platelet count or concentration. We also maybe look at different sort of platelet indices, such as mean platelet volume or platelet crits, reticulated platelets, or so immature platelets or immature platelet fractions may be actually more interesting with more research coming out. And this can be able to describe maybe what happens in the platelet side. With von Willebrand, we still have the kind of same tests that we've always had. It's relatively difficult to get qualitative von Willebrand tests these days, and you need to get specialized labs to perform them for you. And the same really goes with platelet function test, although machines for this, usually sort of aggregometry tests, are found in more labs. We really do not have any standard endothelial lab test still. We can do the buccal mucosal bleeding time, or the BMBT, the clinical test, but we do know that there are some pitfalls with that test as well. And in research, you can find several articles looking at specific endothelial markers. However, none of these markers appear strong enough to make a more sort of routine standardized test that we can offer into clinical practice. With regards to secondary and tertiary hemostasis, I think everybody here knows about APTT and PT, and these are the kind of go-to tests we have basically because they're so easily available. However, we also have to remember that there have to be quite a lot of lack of coagulation factors before they are actually prolonged. And in particular, the activated partial thromboplasmin time can have different activators. So it means that some of the activators are more prone to, for example, neutralizing antibodies in the assay, and that's often related to inflammation. So we may see prolonged APTT without actually having a bleeding anomaly, but purely because the patient is extremely inflammatory. For the fibrin, or the fibrinolysis part, we have thrombin time, from fibrinogen, D-dimers, and fibrin degradation products. And for looking at anticoagulation, antithrombin is often a test that's readily available, but for specialized labs, one can also look at protein C, plasminogen, or single coagulation factors, specifically if we want to look at, for example, inherited coagulation factor deficiencies. And then we have the global tests, thromboelastography and thromboelastometry. And it used to be whenever we had to decide, we really had to spend a lot of time talking about the setup because they were quite new to people, and they may still be new to some of you, but some of you might actually have them as a bedside test now. So basically we have a whole blood test, so we have everything in it, the cells as well. And they can tell you something about the initiation, amplification, and propagation, as well as fibrinolysis of the blood. So basically you have a cup with a small pin, and one of them are rotating, so the clot is formed and then the clot is lysed. So you get basically everything in a cup. And that sounds pretty perfect. Well, I guess I've proved my point. Nothing is perfect, is it? So it's these little guys here, and we basically have we can run 2 tests at a time. It's patient-near test. We run the test within a couple of hours. Usually it rests for half an hour, and then we run the test straight away. It looks at formation of the clot, the kinetics. It looks at strength and resolution. So really a lot of the parts of the coagulation. And you get a trace a bit like this, where you look at the R value, the alpha and the K, the MA and its derived number, which is called G. And then you look at lysis. So lysis after 30 minutes and lysis after 60 minutes. So you really get a trace, you get a visualization of a clot is happening and a clot is lysed. And then you can actually look at different parts of it and kind of suss out which ones are related to specific parts of the hemostatic process. So R starts to initial clot, but tells you something about the coagulation factors. K and angle are time and degree of clot formation, tells you something about coagulation factors, platelets, and fibrinogen. Whereas MA and G tells you something about the firmness of the clot, platelets, and fibrinogen. And then you have the lysis product, where you look at lysis after 30 minutes, and as I said, after 60 minutes as well. And that tells you something about the degree of lysis. Do you, for example, have hyperfibrinolysis? So I've just brought forward some examples of patients from our clinic. So this, over here on the left-hand top, we have a normal coagulable TEC from a dog. Underneath that, there's a hypercoagulable TEC, so potentially a prothrombotic TEC. We also run TEC in cats. This is a cat that's hypercoagulable with a slightly long R time. So this is actually a cat that's going into DIC, where it's starting to lose its coagulation factors. I realize this might not be so easy to see for all of you guys, this dog, but I really wanted to find one of the worst cases I could find. So this is a hypocoagulable TEC in a dog, where this is basically just the R time. It doesn't have any coagulation factors. It's just never producing any clots. So this is the one where you just stand there and watch it in motion, and you just run and find those blood products straight away. Finally, we have an example of hyperfibrinolysis in a dog. This is a patient with Angiostrongylus fusarium. It's very prevalent in Denmark, that little larvae, parasites, where you have a clot formed. We actually ran it twice, where you have a clot formed and then the clot just collapses straight away. So, initially we thought that was just going to be all the answers to our prayers, but life is just never that simple. So we could see in Bo Wienberg, one of my colleagues, in 2009 identified that a hypocoagulable TEC was more predictive of bleeding in dogs than both ABTT and PT. And when the TEC still appeared relatively robust, so whenever he spacked it or respacked it a little bit with TPA, it became even more sensitive to fibrinolysis, and we could see that it could uncover occult hyperfibrinolysis in a range of cases that were bleeding, and we didn't know why they were bleeding. All other tests appeared normal. And this has also been documented using ROTEM, so that's the type of global test that have shown with their kind of tested up overt hyperfibrinolysis in a range of conditions, both in dogs and cats. However, hypercoagulable TEC traces do not seem to be predictive of thrombosis, unfortunately. So Clara here, she worked in a project in Copenhagen in collaboration with Penn State, and where they looked at a lot of dogs with thrombosis, and she just couldn't predict which patients would develop thrombosis or not, unfortunately. Also, even though several authors, ourselves included, have looked at TEC and ROTEM in cats, and also it's published, I would still say I still find it relatively difficult to interpret TEC traces in cats. So even though you sometimes get these beautiful patterns that very much look like what you see in dogs, the whole thing about very hyperactivable platelets in cats means that they may get this what we call clot retraction. So basically the clot just clumps very fast, and it's impossible for you to say anything about the fibrinolysis part, and even the sort of MA part may be difficult to assess. So cats, as they are notoriously, are just very difficult. So then, should we just go back to D-dimer that we've always thought of as the obvious thrombosis marker? Well, we know, as I said earlier, that increased D-dimer is an indication of degradation of cross-linked fibrin, and it also occurs in natural thrombosis. We know it's increased in post-surgery, in internal bleeds and neoplasia. So how can we then use it? Well, several studies have shown that D-dimer seem to have a high diagnostic sensitivity but a low specificity for thrombosis. So if it's positive or high, you might have thrombosis, but you might also have something else. And if it's quite low or lower than your cutoff, it's less likely that you have thrombosis, so maybe we can still use it as a rule-out test. It's primarily studied in dogs, and there are many different assays available. And this is actually a problem in human medicine as well, so you can't really transfer your cutoff values. You really have to have a lab that kind of specializes in this and have their own cutoffs. And we do not have any veterinary standardization. Basically, our D-dimer tests are human tests that we apply to animals, which means that it could be that we're measuring D-dimer and something else as well. We don't know. This could potentially also be the reason why D-dimer is less reliable in cats. There are a couple of studies out there that have found that patients with thrombosis still have low D-dimer, so that's very difficult to work with. On a note here as well, I think it's important also to know that in human medicine, particularly in patients with chronic kidney disease, D-dimer is even more difficult to work with because of the clearance. So you may have an even lower specificity of this test. And that's why in people, they actually consider doing algorithms or titrating D-dimer in relation to renal clearance to see if they can sort of improve the test, to figure out which patients are prothrombotic and which aren't. So there are other new lab markers that might be interesting. There's thrombin generation tests. It has been around for a while, and there are several publications out there in dogs and cats, actually. And it seemed to be quite interesting to look at. It basically produces sort of a similar pattern as the text, so we get like a visual curve looking at thrombin generation. It hasn't yet proved diagnostic for thrombosis, but really we still need to look at really good studies looking at these high-risk patient groups as well. It has some benefits as it's a plasma test, and it means that it can facilitate sampling from practices or even bigger practices to specialized labs, whereas both TEC and ROTEM really requires you to have the equipment yourself, or certainly you need to have a very short time frame. There's also been discussion whether circulating microparticles can be good tests for thrombosis. Certainly it's proved in human medicine that they have a very strong prothrombotic property. Circulating microparticles are sort of remnants from either platelets, but can also be sort of little tiny phospholipid membrane remnants from, for example, inflammatory cells. And it's also seen in neoplastic cells as well. We have validated them for the use of them in cats and dogs using flow cytometry in the lab, but we still haven't got the data or the big setup to say how important they're going to be in patients prone to thrombosis. So that would be an interesting area for further exploration. So to conclude on this talk, hemostasis is very much a cell-based process. And although we clinically divide it in specific parts of the physiological process, it's heavily intertwined, as I know you well know. Thrombosis is a high-impact comorbidity in dogs and cats and gives us a lot of headaches when it comes to lab testing. The lab diagnostic panel for bleeding is improving and can assist a bit more in molecular localization, but the diagnostics for thrombosis remains quite poor, even though there are interesting new tests in the pipeline. So with that, I will conclude my first talk with a picture of our hospital, and here if you have any questions.
Thank you, Lisa, for an excellent and comprehensive talk. Do we have any questions from the audience? If we do, if you could just wait for a microphone to come to you. No? Have we got any questions? No questions. You
No
covered everything
questions.
completely thoroughly everywhere.
You're either just baffled or...
Great. Well, I think given that we're a little bit behind time, we'll just move on to the next
Yes.
talk. So that's coagulation status in kidney diseases and antithrombotic therapies.
Yeah. Okay, so we'll carry on. So coagulation status in kidney disease and antithrombotic medication is our next talk, and now you're up to speed in all the different small molecules that we're going to talk about. And there will be a test afterwards. Same disclosures as before. So here, now we're going to talk about hemostasis in kidney disease. What's the evidence? We're going to talk about antithrombotics and what can we recommend. And then we're just going to talk a little bit about pharmacokinetics of having disease in the kidney, particularly regards to antiplatelets and anticoagulant medication. So, what do we know from human disease? In human disease, we talk more about nephrotic syndrome, and within this clinical entity, we have diseases, several conditions, where they can have protein-losing nephropathy. And I've just listed 4 of these conditions. There are potentially more as well. However, currently, there are some discussions, but currently it's still only membranous nephropathy or idiopathic membranous nephropathy where they recommend treatment with antithrombotic medication. In those patients as well, it seems to be more venous thrombosis. That's the problem. Deep vein thrombosis is one of the ones that they tend to see. And when they try to describe what happens in these patients, they seem to be quite vividly hypercoagulable. So these patients have increased fibrinogen, increased factor VIII, and we have to remember in people, factor VIII is also an acute phase protein as well as fibrinogen, but it could also be retention. They have increased platelet adhesion, a reduction in antithrombin and protein C and S, reduced amount of plasminogen, and an increase in PI1, and this was one of the regulatory mechanisms for TPA. So basically, it actually fits relatively well with them being prothrombotic or hypercoagulable and developing thrombosis. Things just become slightly more modeled if we go outside looking only at protein-losing nephropathy, but start looking at chronic kidney disease in people. And that's because there's actually been a lot more research going on in this area in people because they're a little bit uncertain how best to deal with this condition, in particular when it comes to hemostatic abnormalities. The patients have an increased bleeding diathesis, and it's considered to be secondary to uremic toxins. These toxins can lead to an increase in nitrous oxide and therefore a deactivation of platelets. There also seem to be dysfunction of the platelet surface receptors, and that can be several receptors, and an altered release of ADP or serotonins from the platelets themselves. Furthermore, they may see an increase in tissue factor pathway inhibitor, so in that sense also inhibiting the clot formation on the protein side. So bleeding in chronic kidney disease is probably not a surprise. This is probably something we would expect. But then they also see patients presenting hypercoagulable. And these patients may have systemic hypertension. Again, not surprising, but they do have that as well. Platelet hyperreactivity, and they have again an increase in von Willebrand, which is also an acute phase protein in humans. They may have dysfunctional endothelium where a decrease in TPA release, so the clot is not cleaved, or an increase in tissue factor, so the clot is happening faster. And again, an increase in fibrinogen and D-dimer, an increase in pi1. So you both have bleeding in some patient groups, and you have hypercoagulability in some patient groups. And people with chronic kidney disease are prone to thrombosis. And then you also have some patients presenting with both. So they may present bleeding, then they may have some kind of vasculopathy or deactivating platelets, and then at the same time, they also have other clinical signs associated with hypercoagulability. So that means that all the understanding we had of how the hemostatic system functions just goes really straight out the window. But probably it's because there's so much more going on that we probably can't measure. And certainly one thing that we are definitely missing whenever we look at this is the endothelium. So endothelium is a big part of having chronic kidney disease, but we can't really see it. And we know that in dogs as well, we may see prolonged bleeding times in patients with chronic kidney disease. But the reason, well, whether we can also have a sort of an increased reactivity in the endothelium, we simply cannot measure that. This is actually called the paradoxical hemostatic potential in patients with chronic kidney disease. We know very little about acute kidney injury. Mostly we know that they're strongly inflammatory, and it's probably related to the underlying conditions. There's not that many studies out there looking at acute injury and hemostatic dysfunction, but what they tend to see is hypercoagulability, an increase in D-dimer and fibrinogen, and there has been in people seen venous thrombosis, but it wasn't significant compared to other conditions that were compared to. So probably we do not have to think about hemostasis regulation the same way as we do in particular in PLN. So then what do we know in dogs? Well, there's actually quite a few studies out there looking particularly at protein-losing nephropathy. These are studies either looking at thrombosis, and then there's a great proportion of these patients that actually have protein-losing nephropathy, or there are studies out there zooming in directly on PLN patients and trying to describe what kind of coagulopathies they have. So all in all, it appears that there's a high degree of thrombus formation in dogs with PLN. And looking at these percentages, they quote everything between 6 and 42%. This is not a prevalence. This percentages compared to the population they specifically look at. So I think that's quite important to remember whenever you read it in the papers. The type of thrombi really varies. The most common one we see are pulmonary thromboembolisms, so arterial, but we may also see other arterial thromboembolisms and aortic or venous thrombosis. So there's actually everything really happening. When we look at these different patient groups, they're usually clumped together. So we do have patients both have patients that have amyloidosis and patients that have some kind of glomerulonephropathy. So rarely do we have one very similar patient group looking at that one. But there have been a study looking at amyloidosis in Sharpes comparing to non-Sharpes, and we still saw thrombosis happening here, even though more so in dogs that were non-Sharpes. The degree of protein loss varies, so it's not necessarily the level of protein that tells you whether they develop thrombosis or not. And very often these are just case descriptions. So if we have to think about the degree of evidence, we really do not have that many control studies. So I'm just going to point out the Donahue study from 2011. It's a relatively small study looking at dogs with protein-losing nephropathy, of which there were 11, comparing to renal disease, of which there were 7, and inflammatory disease and healthy dogs. So in the renal disease patients, these patients were non-proteinuric patients. When she compared these patients, she both looked at their sort of hemostatic changes, and she also looked at whether these dogs developed thrombosis. And only 3 dogs developed thrombosis, and they were all in the protein-losing nephropathy group. And what Donahue also were looking at, and what most people seem to be looking at whenever we look at the studies, is that these dogs have changes in their hemostatic lab tests. And even though they have that, it's still not as clear-cut as what we tend to see in people. So we may see low or low normal antithrombin activity in many dogs with protein-losing nephropathy. However, the degree of antithrombin activity does not seem to predict which dog develops thrombus formation. So therefore, other strategies have really been put into place trying to characterize these patients, and therefore many patients groups have been evaluated using these global hemostatic tests that I was just showing you, either TEC or ROTEM, and found that many of these patients are hypercoagulable. So again, prone to thrombosis, but we just can't use the test to say that they will get thrombosis. White and others in 2016 looked at 76 dogs with protein-losing nephropathy and tried to assess the relationship between hypercoagulability and clinical and lab variables. So these hypercoagulability, she wanted to know, well, if I don't know that they're going to get thrombosis, is there a different reason why they become hypercoagulable? And she looked at both things like systemic hypertension, albumin level, antithrombin, etc. And unfortunately, she couldn't really find any specific correlation. And in her group, she found 89% that were hypercoagulable. But what I actually personally find very interesting is that she found 9% that were hypocoagulable. And we don't know why that is. And it really wasn't discussed in greater detail. But certainly, again, there may be some changes in the hemostatic system that we are just not measuring that are happening in our patients. Besides these findings, looking specifically at coagulation factors, so single coagulation factors, they are often increased in these studies. And we've seen changes in protein C both increase and decrease. So things are just really not as clear-cut as what we've seen in people. And as I said in the initial talk, none of the markers can predict which of these dogs develop thrombosis. So then, what do we do? Well, we have to look at chronic kidney disease in dogs as well. And these guys have a very variable hemostatic change. We do see an increased bleeding tendency. There are histopathological studies documenting uremic vasculitis. And people discuss whether you can call this a uremic thrombocytopathy or thrombocytopathy. There are studies showing an increased platelet reactivity and other studies showing a decreased platelet reactivity. And these are patients that are not treated beforehand. So we really can't fully understand what's going on. Dudley from 2017 looked at a case control study of 11 dogs with chronic kidney disease, stage 3 and 4, and compared these to 10 healthy dogs. And in her studies, she saw that dogs appeared to be almost all of them hypercoagulable. So they had hyperreactive platelets, they had hypercoagulable global hemostasis tests. They didn't see any difference. She didn't see any difference in antithrombin or APTT and PT. And when you looked at the UPC, even though the median was 0.8, she did have some of these dogs going into the protein-losing nephropathy kind of group. There was an increase in fibrinidin and a slight increase in D-dimer. None of the patients developed thrombosis. And it really wasn't very well described whether some of these patients actually had bleeding tendencies either, but there certainly was a lot of changes going on in the system. So how do we interpret that? Well, maybe these dogs are just displaying what we see in people as well, that we have these paradoxical hemostatic potentials going on. But the question is currently, how should we deal with it? Well, there's not recommendations right now saying that these patients should be treated for thrombosis at least. But it's certainly something that requires more research and more in-depth understanding. And as I said earlier, it can be related as well to the endothelium as well. We don't know anything about the vasculature unless we do it post-mortem or histopath. And perhaps we should be better at measuring more regulatory mechanisms than we do currently. With acute renal injury in dogs, again, we have some information. There's a couple of studies out there, and they're very similar to what we see in humans. So we really have inflammation going on, hyper and hypocoagulable global tests observed. Some dogs present with prolonged APTT, some with prolonged PT. Some dogs have thrombocytopenia. There have been signs, in this study there were signs of bleeding in 4 out of 17 dogs, and a different study has also shown that there seemed to be a reduced platelet reactivity in these patients. So maybe they're just inflammatory. Certainly, I think currently I would not start treating them in any particular way with regards to the hemostasis system just now, before we have more evidence. I think there's only a few studies out there. Well, what about cats? Well, I can just ask all of you to go home and design a study in cats, please. We just don't know enough about cats in general. And I think it's kind of a thing in our lab when we do research, hemostasis research in cats is always, well, it's just cats, isn't it? Do cats develop thrombosis when they have protein-losing nephropathy? Maybe. Data is very, very limited. There are 2 studies out there looking at cats with kidney disease, not just protein-losing nephropathy, but kidney disease in these thrombosis studies, with a total of 5 out of 46 developing venous thrombosis. There are several other studies looking at thrombosis in cats without any cats having obvious renal disease. So we don't know how big an issue this is for cats. Maybe, it's been discussed that maybe cause and effect are different than it is in dogs. It's entirely possible. The cats are still not small dogs. But we really need some more multi-center studies looking at this, because there's just not enough cases. It appears that protein-losing nephropathy in cats is so much rarer than it is in dogs. Rail et al. In 2020 looked at survival and histopathology in the cats with protein-losing nephropathy, and in these cases she could see histopathological changes that seemed in proportion identical to what she used to see in dogs as well. But when she looked at survival, these cats had sort of a median survival of less than 3 months. So they really didn't live all that long. And maybe the time frame is just too short for us to know anything about whether they developed thrombosis. We think that cats with chronic kidney disease have an increased tendency to bleed. All of us that have ever been in clinics think that sometimes they bleed a little bit more after a blood sample. But there's actually not that much evidence out there. And I thought this is one of the things you just know is in every single textbook. It's one of the reasons why we also have this, or just one out of many reasons why we think they also are anemic. But there's really not that many studies out there looking at this or quantifying it. A single study has looked at platelets in a group of CKD cats and looking at using platelet aggregometry and found that these platelets were hyperreactivity, so more hypercoagulable. And again, maybe it's disease related. It's a bit like this paradoxical finding that we also see in dogs and people. But then again, it's cats and it's platelets. It's stressed cats with platelets and chronic kidney disease. Probably it can be a feature just of being a cat. Okay, so going into antithrombotics in dogs and cats, I will use the consensus panel and the work that they have been done in 2018 really to give us a guide. And it's recommended to use antithrombotic medication in dogs with protein-losing nephropathy. Protein-losing nephropathy, as I've said, is very weakly associated with venous thrombosis in cats. And if you remember the 3 different groups I had in the first talk, PLN in cats is kind of in the middle group. So if you have more than one risk factor, then maybe you want to treat them. And so we're just going to talk about antithrombotics in dogs and cats. So the preventive use antithrombotics, we divide them into prophylactic use for arterial thrombosis and for venous thrombosis. So for arterial thrombosis, we favor antiplatelet medication to anticoagulant medication. And these are really clopidogrel and aspirin we're talking about. And this really sort of talks into our dogs with protein-losing nephropathy, where more of these patients have arterial thrombosis. So in dogs, there's actually not a recommendation using clopidogrel versus aspirin, because we have more knowledge of aspirin. We're gaining more and more knowledge now, I'd say, as well, about clopidogrel. But study-wise, the panel out there are not recommending one or favoring one over the other. In cats, we have a clear recommendation for clopidogrel, really based on the fat cat study in 2015 in cats with cardiomyopathies. With regards to venous thrombosis, anticoagulants are favored compared to antiplatelet medication. We just listed unfractionated heparins, low molecular weight heparins, and these direct oral anticoagulants, the DOACs, as we call them, such as rivaroxaban and neurofactor 10A inhibitors. And when you look at the panel, what they discuss is that you can discuss using them all, but they have different benefits. So unfractionated heparin versus low molecular weight heparins, well, it's probably more convenient to use low molecular weight heparins. But then again, the rivaroxaban or the other sort of DOACs are all drugs. And I think it's just a question about time before we get more and more experience with using them and see more studies, then we probably will go more into that direction. There's also discussion about use of combination therapy. If we have patients where we have already seen thrombosis and we want to ensure that they do not get continuous thrombosis, people discuss whether you can do combination therapy. And there's not a sort of, they're definitely not saying that you should not do it, but they're kind of not saying that you should do it either. And I think in particular with regards to these kind of patients here, patients that may have decreased GFR, we should definitely think about it. If we start using more drugs at the same time, we will also increase the potential for side effects such as increased bleeding. So that really leads us to talk about pharmacokinetics. And I'm very happy to stand in front of you guys talking about this, because I think you guys are instrumental in this. If you work a lot with kidneys, you will have to think about pharmacokinetics so much. And I'm sure that you guys can probably later on comment on how we're going to solve this problem. So I've just chosen some of the drugs just as examples to say, well, how are we going to deal with this? So example is clopidogrel. We know from human medicine it's activated in the liver, excreted equally in urine and feces. There's been a multitude of human CKD that show equivocal results whether we use the recommended dose or whether we use a reduced dose. And because they're so concerned and so much concern about thrombosis, it means that they now use the sort of general normal dose even in patients that have a reduced GFR. In dogs with PLN, it appears a dose reduction does not need to be needed for clopidogrel and aspirin. And this is all based on one study, but we still have one study that seemed where we could see platelet aggregation happening, and we didn't see an increased tendency for bleeding. We don't know anything in cats. There are a really nice study looking at pharmacodynamics in cats, an old Hogan study as well, before it was really applied to cats with cardiomyopathy. But we don't know anything about cats with renal disease. With regards to low molecular weight heparins, most of them metabolized by the liver and primarily excreted in urine. And human studies actually have shown a 17 to 44% reduced clearance in renal disease in these drugs. That's quite massive. And therefore, FDA recommend dosing intervals are prolonged. So basically what they tend to do in humans is that they tend to give the drug twice daily usually, but in patients with significant kidney disease, they basically get once daily dosing and then the same dose. We don't know anything in dogs and cats. It has been suggested that we should probably follow these human guidelines and therefore do dose reduction as well. But then renal clearance in dogs and cats and renal clearance in people, I guess this is your area of expertise to show, can we just translate? This is what we usually do. Under all circumstances, we really have to be cautious. And finally, rivaroxaban, about 33% are directly excreted in urine, the rest metabolized by the liver. In humans, when this drug was first presented, there was dose reduction due to some experimental studies in quite severe kidney disease. However, after using it for a while, also in a lot of patients with renal deficiency, they've now come to the conclusion they can use the normal dose also in these patients. We don't know anything in dogs and cats. Another area that could be looked at, and certainly something that we really need to get some more information about, because I would probably predict that this would be a drug that'd be a go-to drug soon in this group of drugs because it's an oral drug, right? So, that's why I've listed your society. So I'm kind of hoping that you will grab that torch, and I'd love to come here next year and hear all your results of PK studies and PD studies telling us what we should do in these patients. Okay, so to conclude, pathophysiological changes in renal disease are confusing. They're poorly documented in dogs and cats. Dogs with protein-losing nephropathy are predisposed to thrombosis, and therefore antithrombotic medication is recommended. Cats with protein-losing nephropathy may, perhaps not, be predisposed to venous thromboembolisms, but more research is needed here. And we really need to do joint research to try to get into the bottom of this. And antithrombotics can be considered if there are more risk factors present in the cats. We have these broad consensus guidelines. It's important to remember they're broad. They're not made for PLN dogs. They're made for any kind of disease that causes thrombosis in dogs and cats. And they have, at least we have them. They guide therapeutic protocols. But the information of drug dosing adjustments in renal disease in dogs or cats are still very limited. And with that, I will take questions.
Thank you, Lisa. We do have a question. If you could just wait for the microphone, Dottie.
Thank you. Thank you for a lovely presentation. I'm a nutritionist, not a nephrologist. So, of course, I have to ask a nutrition question. And I wonder if you could address the potential, or lack thereof, of omega-3 fatty acids for, for these cases where you're trying to be prophylactic regarding coagulation issues.
Yes. At least in humans, from my time in human research, there was a lot of debate on how they could be anti-inflammatory in some of the conditions as well. I haven't seen the hemostasis studies seeing the changes in the coagulation factors that would be assisting in the disease or reduce the level of thrombosis in the patient groups. But I think it could be very interesting to look at that, because I think there are certainly some information about what happens in the kidneys as well that may need some kind of tweaking, or that could be some kind of anti-inflammatory process that we need to address without pouring, for example, lots of NSAIDs in them, which we really do not prefer to do. I don't have any specific insights. I just know it's a big discussion point in humans as well, because there's a lot of interest in whether people who are thrombosis prone can somehow reduce, because it's quite often grumbling inflammation in the background as well, whether they can somehow reduce that as well.
Do we have any more questions from the audience? We've got a couple of questions from the chat.
Mm-hmm.
What are your recommendations for monitoring if you do have a patient on antithrombotics?
Yes. What are my recommendations for monitoring patients? So again, I would first of all say that this has also been addressed in some of these. I'm very much. I feel like I'm a sort of commercial poster for these publications that have been in 2018. But they do go through what they think could be a guide for how to monitor the patients. In people, for example, with clopidogrel, just as I think it's probably a good example for dogs with PLN, it has been discussed whether monitoring is needed at all. because they've measured the metabolite, the measured concentration, or they measured these different sort of activation tests. And it appeared that whenever they have patients that are functioning on clopidogrel, because there are a fraction of patients that do not function on that drug at all due to genetic changes, they do not necessarily measure them on a routine basis. They just follow them and monitor their kidney disease. There are sort of recommendations with regards to whenever you have to do procedures in these patients. So for example, if patients need a particular surgical procedure, then they will probably suggest that you hold off that drug for a little week before you do the procedure, and then sort of 24, 48 hours after the procedure, you put them back on the drug again. Mm-hmm.
Thank you. We've got another question. If we suspect that a cat with chronic kidney disease has PLN and the serum albumin is less than 2 grams per deciliter, would you use clopidogrel to prevent thrombosis? A very specific question.
That's a very specific question. So serum levels of
2 grams per deciliter.
Of
Albumin.
albumin, yes. I probably would, but I would probably also have like a serious talk to the owner about the whole protein carrying capacity, etc. But we also have to remember that these patients we're treating them in so many different ways as well. We're not just treating them with antithrombotic medication, so we're trying to tweak their disease in different ways as well. And I would probably, these are probably the patients where I would monitor them by clinical examination or potentially consider looking at platelet aggregation because I have that in the lab, so I can do that. But they are quite tricky. And if you think about dogs, it's not easier, I think, when you go into looking at aspirin. There's always this big debate about should we use aspirin, should we not use aspirin in patients with chronic kidney disease. This is the current recommendation, but then when you start seeing quite significant changes, do you get concerned that you're just going to make things worse? So there's really not a beautiful answer to that one, I'm afraid.
Another question. So do you currently make dose adjustments if you're using antithrombotics in your patients where you have evidence of reduced renal filtration function, or are you just waiting for the evidence to come out?
So currently we're not making adjustments, but we're thinking about what kind of drugs we want to use. So I was kind of very much in a rigid way showing you that we would use antiplatelet medication for arterial thrombosis and anticoagulant medication for venous thrombosis. But there are discussions whether you can use one or the other for that, for the different diseases. Well, you might not have to just use one for the anticoagulant for the venous thrombosis. You might be able to use a different drug. So if I have patients that have significant kidney disease, I will consider this knowledge, and maybe I will try my best to stay clear, for example, of low molecular weight heparins, because that's where I have human evidence, and I have to be extra cautious. Yeah.
Thank you. Any further questions? Great. Thank you, Lisa.
You're welcome.
So we now have our break. So refreshments will be served down on the terrace area on the ground floor. And if we can return for the next set of lectures at 11 o'clock. Thank you.
I'm trying to get this off.